Hi everyone, I'm Elizabeth Moore. I'm Research Fellow and Project Manager with the Myeloma and Related Diseases Registry with the School of Public Health and Preventive Medicine at Monash University in Melbourne. I'm the chair for today's online edition of the VCCC COVID-19 and Cancer Victoria webinar, and that's in partnership with the MPCCC. Before we move on, I'd like to acknowledge the people of the Kulin Nations on whose land today's presentation is taking place. And I'd also like to pay respect to the elders past, present and emerging, and extend that respect to other Indigenous Australians present online. So welcome to today's presentation. The Victorian COVID-19 Cancer Network, or VCCN, was formed in response to the challenges of managing cancer care in the current pandemic. And it's a joint initiative of the Victorian Comprehensive Cancer Centre and the Monash Partners Comprehensive Cancer Consortium. And that aims to provide support and advice to clinicians and healthcare services treating patients with cancer during the COVID-19 pandemic. VCCN collaborates on a digital platform and they provide information and support for health professionals, and that includes initiatives to guide and optimise care for patients with cancer, specialised channels for different tumour streams and areas of interest like telehealth, cancer trials and haematology, and forums for shared problem solving and support. There are some interesting talks coming up in the next weeks. I think you can see those on your screen, and you can register your interest at the VCCC website. There's an open learning page, and you can see previous topics also from webinars in this stream there. So some housekeeping regarding the presentation. If you have any questions for today's presenter, you can submit them through the GoToWebinar platform that you're viewing the presentation on. And please do this throughout the presentation and we'll collate the questions so that the speaker can answer those at the end of the session. So please use the question chat function to submit your questions during the presentation. Now to present our speaker, Professor Maarten IJzerman is the VCCC Professor and Head of Cancer Health Services Research at the University of Melbourne, Centre for Cancer Research and Centre for Health Policy. He's also Professor of Health Technology Assessment in the University of Twente in the Netherlands and leads a global research program that's focused on health economics and service delivery of precision medicine, in particular looking at oncology. And this program includes use of real-world linked health data for health services research and the use of decision modelling methods for biomarker development, patient preferences research and dynamic treatment sequencing. Today, Maarten's presenting the background and the modelling approach to estimate the collateral damage of COVID-19 restrictions on health outcomes, as well as international studies, other international studies in this area. His presentation discusses the opportunity this modelling approach provides to study the impact of treatment delays beyond COVID-19 and present the case for real-time and easily accessible health data to better inform health policy. And now I'll hand over to Maarten.
All right, thank you very much, Elizabeth, for the introduction, and thank you very much for the kind invitation to present at the COVID-19 Cancer Network in Victoria. It's a great privilege to share the work that we do. And before I continue, I actually want to acknowledge the great team I'm working with, and I'm presenting on behalf of the whole team. In particular, I'd like to acknowledge Koen Degeling, who's done quite a bit of the modeling work, and Fanny for the data analysis, and particularly Grace, who's leading the work on the survey design. Okay, in my presentation, I'm going to cover a few topics. I first want to go into one of the reasons for us starting the work on modeling of cancer delays, and mainly flagged by data from the Netherlands, where we've seen a huge decline in cancer incidence. I'm going to talk about some of the global initiatives on modeling of COVID-19 impacts on cancer survival. Then I'll present the work that we've done with our team on estimating excess mortality based on inverse stage shift model. And my final two topics are really about what it actually means for health service delivery, and whether we have actually data to support the change that we've seen in health service delivery. So that's the outline for the presentation. So when we started the work about 2 months ago, we were actually flagged by some from Data of the Netherlands. And this is, in the meantime, this is published in the Lancet Oncology, data from the Cancer Registry in the Netherlands, and they published as early as the 3rd of April. They've seen a huge decline in cancer incidence rates, just only a few weeks after the first confirmed case of COVID-19 in the Netherlands. And you see a drop up to 40 to 60% of the normal cancer incidence rate. So that's a significant decline in incidence. And the drop even has been more significant after the nationwide implementation of strict social distancing policies and suspension of national cancer screening programs for breast cancer and other screening programs. And that's the data until the 6th of April. But if you have a look into the website, you will see that this decline continues even up till the 25th of May. So this is the most recent data from the Netherlands Cancer Registry, where you see that's only 70 to 80% of the normal incidences that have been reported. So there's still a significant decline in cancer incidence, which actually flags the concern that we have in terms of this causing a delay in getting the right treatment early on. And that also, at the same time, we saw on Twitter, I mean, many of you probably have seen the tweet on the different waves of the pandemic. And this is not referring to the second wave of the infections. This is about the collateral damage. This is about the impact of COVID and COVID-related restrictions on health service delivery and health outcomes for some of the other patients, patient with chronic disease and patient with cancer. So we actually have a particular interest in this, the second and the third wave following the pandemic. So the impact of interruptions in care delivery on chronic conditions and on cancer. So that's I think one of the backgrounds for us starting the work. Now, if you look into what data actually has been reported in the literature in the internet on excess mortality, I think I'll first start to refer to the UK, where on top you see the timeline of COVID in the UK starting the 31st of Jan with the first transmission and a lockdown on the 23rd of March this year. And just a few weeks later, the Office for National Statistics published the first reports flagging excess mortality of about 2,500 deaths that are not specifically COVID related. So this is what we call indirect COVID related mortality. So this is not patients affected by COVID themselves, but this is mortality which is caused indirectly by COVID. And they flagged this to be about 2,500 by 14th of April. And that number has even gone up to about 25% of all excess mortality is indirect from COVID. It's due to all restrictions being in place and people fearing to see their GP or being referred or delayed in terms of referral. I hope you can see the slides right now. So this is the slide that I showed about cancer incidence declines in the Netherlands and the ongoing data that's available from the Netherlands and the concern that we have on the second and third wave impact of health impact of interrupted care delivery in chronic conditions and cancer. I'm happy to share all those slides later on so you can have a look if you've missed something. Okay, this is the timeline in the UK with the lockdown down before the 23rd of March and the Office for National Statistics report reporting 2,500 excess deaths indirectly related to COVID. So it's not direct COVID related mortality, which has gone up to about 25% of the mortality indirectly from COVID. So that's where the UK data is from. So then if you go to Australia, and at the time we started to work, there was not really data available in Australia on indirect COVID-related mortality. Just only last Friday, we've got the first publications on mortality following COVID, so from January to end of March. I can present later in my slide deck. But even though there's been quite a few reports in the newspapers and different publications flagging the issue of declines in cancer incidence, and the risk of declines in referrals to hospitals, so including Peter Mac has flagged the declines in referrals to Peter Mac for patients requiring services. So this has been in the news for some time in Australia, even though there's no specific data available. And that also is of interest for us, because if there's no data available, the only thing you can do to actually estimate the impact of delays in referrals is to do a modeling study. And so you've probably seen so many different models, and I'm not an expert in infectious disease modeling, like you see the simulation you see on the left side of the screen. So that's a typical agent-based model that's been used in infectious disease modeling to model the spread of the infection from a specific origin. And those agents are all people within the system that you can model with an active behavior. Instead, we do have a bit of expertise in what we call discrete event simulation models, which is on the other side. So discrete event simulation tries to map a care pathway, a delivery pathway, as a series of events. So you go to a hospital, be referred to a hospital, see a nurse, get a diagnostic test done, get your surgery done, being submitted for follow-up care. So there's a series of events that you can map throughout the care pathway. So this is a typical example of a discrete event simulation model that we use to map the care delivery. And you can also do the same kind of work to actually maximize the use of your capacity. So you can estimate, if I would have more nurses in a particular part of the pathway, can we increase the number of patients that we see in a timely way? And we can reduce the time people are in a hospital or in the service waiting for the appropriate services. So that's more of the health services kind of research modeling that we do and have an interest in. So if you then look into the literature about modeling, and there's a significant amount of work done in the world on modeling the impact of COVID-19. I think most work, and there's been some work in Melbourne too with the Doherty Institute. I think one of the most important resources of modeling is the London School for Hygiene and Tropical Medicine, where you can see the link here on the screen. And they have a repository, so all their modeling work is available publicly through the GitHub repository. And I did a bit of searching on that GitHub, and it gives you about 74,000 hits if you look for COVID-related models. So there's a very significant amount of models available for different questions in terms of the outbreak, prediction, the outbreak, but also the prediction of the different mitigation strategies to manage the outbreak. But there are also some professional societies. So we've done some work with the Society for Medical Decision Making, who have their specific modeling committee, COVID-19 modeling committee, and they have a repository of different models, not just to model the outbreak itself and the mitigation strategies, but also to estimate the maximum capacity the health system requires to manage the outbreak. So there's different sources of models available there. And then finally, if you go specifically into cancer, there's just recently announced a Cancer Global Modeling Consortium, which is led throughout the Cancer Council New South Wales by Karen Canfield. And they focus on the different modeling strategies specifically for cancer in screening, in treatment, and in cancer prevention. So that's in a nutshell what's already out there. So that's a very significant amount. So if I look into some of the papers that have been published, I think this is one of the very first papers that's presenting a prediction model to predict excess 1-year mortality based on real-world data. So this is a paper from the UK again, using data from Calibre and Can-Do, so different large data sets in the UK, predicting excess mortality, and by anticipating also for comorbidities. So they include comorbidities and the risk of collateral damage or excess mortality if you have a comorbidity. They also look specifically in the direct COVID-related mortality and the indirect COVID-related mortality. So that's due to the interruptions in care delivery. And finally, they report that at least 20% of the UK population has one high-risk underlying condition for COVID. So if they get infected, although they have a separate other disease or condition, they're a high risk of dying from COVID. So this is more of a prediction model that's being published. The second paper that we've come across in the last couple of months is this one, which was published online in a preprint journal on the 24th of April, and it's now published online in Journals of Oncology. And this is actually more specific for cancer. The previous one is more general excess mortality due to COVID. But this one is very specific for cancer, where they assume that cancer diagnostics and surgery are disrupted, and progression of cancer is very likely due to delays, and that might affect survival. And they assume that the interruptions in care delivery might be there for at least 18 months. So it's going to be a pretty significant interruption in care delivery. And in their modeling approach, they basically only included the surgical population, so patients that were eligible for surgery, so stage 1 to 3 cancers, eligible for surgery. And they assumed there's going to be a reduced surgical capacity. Again, they used data from public sources, Public Health England, and they estimate from their study, they estimated that a 3-month delay for the 94,000 patients that they expect they would have had surgery in a normal year, there will be an excess mortality of about 5,000 patients due to the delays in surgery. And the loss of life years due to cancer equals 43% of life years gained by hospitalizing an equivalent number of patients due to COVID. So that's more the conclusion that they base on their surgical delays. Then the third paper is basically a follow-up of the other paper that I presented, published in The Lancet, which is estimating excess mortality in people with cancer and multi-morbidity. So they combine both the direct and the indirect effects of COVID, but they also look specifically into multi-morbidity and whether that would increase additional excess mortality. And the background for this paper is a survey, a Macmillan survey in the UK, reporting that 45% of patients had seen their cancer treatment delayed, cancelled, or changed. And they actually based their model and their analysis on real-world data. So this is data they published in their paper from several major hospitals in the UK. As early as February 2020, you see a decline in chemotherapy procedures and less urgent referrals to those services. So they estimate about 45 to 70% of patients receiving less chemotherapy and up to 70 to 90% less urgent referrals for cancer diagnosis. So their modeling approach is pretty much based on the other paper predicting excess mortality based on comorbidity in the population. And they combine both the direct and the indirect effects of the pandemic. Unfortunately, at the moment, the paper is not very detailed in terms of the modeling approach that they use, but they estimate about 6,000 excess mortality, excess deaths in 1 year in the UK, and by only looking into incident cases for about 24 different cancers. So the other paper was 15 cancers. This is 24 different cancers. This is a more pan cancer, whereas the other paper was 15 cancers specifically for surgery. And the number of comorbidities was strongly associated with cancer mortality risk. So 78%, nearly 8% of the excess mortality occurs in patients with one or more than one comorbidity from that specific paper. Now, if we go to the work that we've done in Australia, is here. So this is published also in a preprint journal, the same preprint journal. It's by the end of May published. And in our paper, we actually only look into the indirect effects. So we don't include the direct COVID-related mortality. And one of the reasons is that COVID's been managed pretty well in Australia compared to the UK and some other European countries. So we only look into the effect of care interruptions, so delays in access to care and delays in referrals and potential delays in surgery on excess mortality. The other thing that's very different is that we didn't have any prospective data available. So we couldn't populate our model with real world data from registries like done in the UK with Collateral and some of the other population level data sets. So we had to come up with a modeling approach that we could make flexible to update with new information once available. So, but still the same assumption was that there are indications of delays based on the reports by Peter Mac and some of the other, the Royal College of General Practitioners and Royal College of Pathologists was recently flagging the issue of delays and declines of referrals. So there's pretty good indications that there's delays in access to services. So there's aggregate data, and if you update this little picture to explain, so the UK modeling approach really is based on prospective data collection using the large population-based registries, analyze registries, see a decline in referrals, see a decline in chemotherapy prescription and use that as an input for a model, a computer-based model to predict outcomes, and potentially they can predict costs. So for Australia, we did a little bit of a different approach. So here we actually started with publicly available registries, so we can look into state distribution data from the Australian Institute for Health and Welfare. We can look into the literature for survival of specific stages of cancer. We can look into costs of treatment. And we use those aggregate data from different sources to develop and populate a computer model to predict the outcomes and predict the excess healthcare costs. And then, of course, we want to use prospectively collected data once available to update the model. So we can iteratively update the model that we do to produce better estimates, more precise estimates on cancer mortality and excess healthcare costs. So that's a little bit of a difference between the two modeling approaches. So with the absence of prospective data, I think this is the best way we can go ahead within Australia. So the model approach that we've taken was based on a stage shift model. We can refer to that as an inverse stage shift for the delays. So the stage shift model has been out there for quite some years. So it's published in 1989 and based on stage distribution at diagnosis. So this is just based on Australian Institute for Health and Welfare data, National Cancer Indicator data. So stage distribution at diagnosis based on 2019. And you can use it to map the distribution of your population according to stage. So this is for lung cancer. The base case, so most of the lung cancer patients are diagnosed in stage 4, nearly 50%. For each of those stages, we know pretty much what the 5-year survival estimate will be. So if you're diagnosed at stage 1, 92% of the patient will survive 5 years. So that's going to be the 5-year survival estimate. And then you can multiply and estimate that about 31% of the patients will still be alive in 5 years' time. So if you now take the screening, and the idea of screening obviously would be to diagnose patients early at a less severe stage. So here you would expect a change in your stage distribution from the more severe stage 4 to the less severe stage 1 and 2. We can, if we estimate this, so we can assume that based on the screening, implementing a screening for lung cancer, you can assume that the stage distribution is changing and the overall survival would be beneficial. So we're going to be 39% of the patients surviving the 5 years. Now with the inverse stage shift model, we would assume a delay. So if there's a delay, we expect there will be some patients progressing to a more severe stage. So again, we can assume the stage distribution to change, and it's going to be more patients diagnosed in a more severe stage. And that leads to 29% of patients surviving the 5 years. So that's basically the idea, the underlying assumptions for an inverse stage shift model. And you can, I mean, the previous slide pretty straightforward with the overall the percentage of patients alive at 5 years, but you can also use survival curve estimates. So this is a survival curve for every single specific stage. So this is the distribution with the stage of a diagnosis, and you can see those stages in the survival curves on the right side. So stage 1 definitely on top, and based on that you can compute an aggregate or an overall survival curve for the whole population based on the stage distribution. And then if you would do the same for the modeling, you can model the screening scenario, you can model your delay scenario. So this the red one would be the average survival curve for the whole population. If you would implement your screening, it will go up to the blue one, and with the delay, you end up with the green one. So that's where you add your survival curves into your modeling strategy. And those survival curves are pretty much available from different data sets and different registries. You can estimate the survival curves pretty robustly. So in the modeling, there's two critical parameters there. I mean, there's a few assumptions, obviously, but there's two critical parameters. One is the delays that we can expect in the time to treatment initiation. And so this is based on work that's being published in particular in primary care, looking into diagnostic delays. And this is the whole treatment pathway where you can identify different components that cause a delay. So there's diagnostic delays based on patients going and see their GP, but also delays within the GP or delays in referring to a hospital and delays in getting your diagnosis done. So there's different sources of delay. And there's a treatment delay, the delay from diagnosis to start of the treatment, start of surgery. So you want to map the whole delay in terms of getting access to care, because that's the key interest. So we want to know what the total delay will be in terms of getting your right treatment as soon as possible. So that's a critical one. There's not a lot of information on this because you really need a linked data set from linking cancer registry to primary care to hospital admission data to be able to map the whole delay or the whole process here. That's not available yet in Australia. So we have to make assumptions about that treatment delay, which is either 3 or 6 months. So we use the same period of delays as in the UK-based papers. The second critical thing, just to summarize that delay, the evidence, the current evidence on delays and survival, because that's the critical thing here. That because when we started to work, that people say, well, it's commonly accepted that cancers grow pretty slowly, so some delay might not affect the outcomes too much. There's some guidelines recommending specific time intervals to start the treatment, but there's not a clear evidence on that in terms of survival. But nevertheless, I think the best available evidence that we have at the moment for diagnostic delay and cancer survival comes from a systematic review from Neil and others in the British Journal of Cancer, saying that it's reasonable to assume that efforts to expedite the diagnosis of symptomatic patients are likely to have benefits for patients in terms of improved survival, based on a large systematic review, over 100 different papers reporting on this. And there's some specific cancers that they raised that have a much clearer relation between shorter times to diagnosis and more favorable outcomes, which is breast, colorectal, head and neck, testicular, and melanoma. And in our discussion, we also had a very interesting and sensible comment that rurality as a factor is also very important to consider here, because we know that stage of diagnosis in rural areas usually severe compared to metropolitan areas. So that could explain some of the delays and some of the disadvantages in terms of survival for patients in remoteness areas 4 and 5. So that's all about time to treatment initiation and delays. The other critical piece for the modeling is that we want to estimate stage shift. So can we likely estimate the time to stage progression? How long does it have to take to progress to more severe cancer, to progress one stage? And that's more critical. And you need some really population level data. Ideally, you want a tumor growth model, but that's very complicated to use in a reliable way. So in this modeling work, we looked into 4 cancers. We looked into colorectal cancer, breast cancer, and lung cancer. And we used population level data reporting on the surgical delays and overall survival. This is based on US data published in this Corona paper in 2019, using a large population level SEER data set. And based on that data set, you can calculate the hazard ratio of delays in relation to overall survival. So that's where that's more observational data we used to estimate the time to stage progression. We did a little bit of a similar, different approach for melanoma, in which we used a tumor growth model. And here we used a hazard ratio progression based on the breast thickness that was reported in this paper of Liu. So that's the 2 approaches that we used in estimating the time to stage progression. Then it's not fair to assume that everyone has a delay and everyone has a progression in the same way. There's probably pretty significant heterogeneity in your population. So some patients may progress earlier than other patients. Some patients may experience a longer delay than other patients. So we assume the delay and the time to stage progression to be a normal distribution. So if this is the normal distribution for time to disease progression, this is the delay here, the time in months it could take. So on average, it's going to take 6 months for the median group of people to progress to the next stage. But you see there's a few patients that have less time. They can progress in 2.5 months, and there's probably a few people that need more than 10 months to progress to the next stage. So there's significant heterogeneity in the time to stage progression. So we include that in the model, and you can do that pretty simple by using by developing a cumulative distribution from this normal distribution. So here you can assume that if you would delay up to 6 months here, so a 6-month delay, then we would estimate from this normal distribution that about 42% of the patients have progressed to the next stage. And you can use the same curve so if we would have a 3-month delay, what would be the proportion of patients that will progress to the next stage? It's going to be about 5% in this case. So by using this kind of cumulative distribution, you can select your time frame, select the delay, and then estimate the number of patients that would progress to the next stage based on your delay. And in our modeling work, we've used a 3 and a 6-month delay as a base case. So let's move to the results. So this is the 4 cancers that we looked into with the 3 and the 6-month delay that we assumed. And this is the incidence rate. So about 20,000 breast cancer patients in Australia based on Australian Institute for Health and Welfare data. The incidence of stage 1 disease. So we only look at stage 1 disease for breast, colorectal, and lung cancer, and we look into T1 stage for melanoma, so we can map it against the breast node thickness. So this is the incidence, the true incidence of patients diagnosed in an early stage. So 43 breast cancer patients and about 62 diagnosed at T1 stage, and more severe stages in lung cancer and colorectal cancer. Then this is the probability that you progress to the next stage. That's the next row. And this is the actual number of patients that do progress. So in the breast cancer case, we estimate only 1% of the patients who progress based on a 3-month delay. It could go up to about 5% for the 6-month delay. So that's where the actual number of patients that progress to the next stage come from. And then we estimate the excess mortality in the next 5 years. So we take a simulation interval for the next 5 years. So for the 3-month, we expect there's going to be 6 excess mortality, excess death in breast cancer alone if we experience a 3-month delay, which go up to 25 for a 6-month delay. And in total, we have estimated for all the 4 tumors together, we estimate that there will be 90 excess deaths based on a 3-month delay. That's going to be a conservative estimate. But that could go up to about 500 if we experience a 6-month delay. Then in terms of excess healthcare costs, we can do the same as we do for survival, but then extrapolate the cost of treating a stage 1 disease. And if we do that based on literature data on treatment costs, we can assume that the total cost, the excess healthcare cost, will be 12 million for a 3-month delay, up to $45 million for a 6-month delay. So some of you might observe there's not really a difference for lung cancer, and this is mainly caused because there's not a significant difference in cost in treating a stage 1 and a stage 2 lung cancer patients. It's roughly the same. So that's why there's no incremental cost of progression to the stage 2 for lung cancer. But that might be very different if we would also consider stage 3 and 4, both in terms of mortality and in terms of excess healthcare costs. So again, pretty conservative estimates. So the modeling approach actually is available, so you can access this through the web. So we've had the simulation model available on the web, and you can select. So if you go to the link is here in the slide, but you can select the default values that you will have an interest in. So if I have interest in breast cancer per se, Australia for 3-month delay, you see you can select those data sets, and they'll automatically load into the simulation And then it predicts the expected survival for that population based on that stage progression, and then also expect the effect of your delays based on your stage shift. So that's going to be available, and you can use that. And you can use that pretty flexible for any kind of stage distribution. So we also do some work on whether the stage of diagnosis in rural areas is different from the metropolitan area to see whether that explains difference in survival outcomes. So just to wrap up the different models, specific cancer models that I've presented. So there's 3 of them at the moment that I've seen. And also oncology is just published in May, and 2 are available in preprint. One based in the UK, they applied it to the US as well, and 1 specific for Australia. Only 5 cancers, and they consider the direct mortality and the indirect mortality, whereas the Australian study only considers the indirect mortality due to the COVID-induced restrictions in care delivery, so care interruptions due to COVID, whereas the UK also considers the effect of COVID's infections in cancer patients, either with or without specific comorbidities. So there's definitely huge differences between the modeling. So this is based on real-world data. We use aggregate data and we update based on real-world data. But there's very significant differences in the severity of COVID. So the outbreak in the UK, as you know, is much more significant compared to Australia, with only 102 deaths in 104 at the moment in Australia. But even though we estimate a pretty significant excess mortality just due to the COVID restrictions, just based on that stage 1 to stage 2 progression. So every model has to make assumptions. So that's the same for us. So we have to make assumptions about the effects, and we have to make sure that we come up with a very conservative estimate. So one of the assumptions is that we only look into the indirect effects. As I said, that's mainly because the COVID outbreak is less severe in Australia. So we've done pretty well managing the outbreak, but we still suffer from restrictions or due to COVID, so social distancing and reduced capacity potentially in hospital services. And that's been confirmed. And this is really recent data. This is just published last Friday, cancer specific mortality statistic for Australia. And if you look into cancer-related mortality, you see there's up to 31st of March, there's not really an increase. There's no excess mortality due to cancer during the COVID outbreak. And that makes sense because there's so few patients being affected with COVID. And the effect of the indirect effects is going to be a long-term effect, because if there's going to be a delay or interruptions in care delivery, we expect that delay to be visible just in a few years from now, not right now. So that makes perfectly sense. So the model that we've done, as again, is a conservative estimate. We only consider stage 1 to stage 2 progressions. We only look into 4 models. We don't consider comorbidities, which might be very relevant to look into, and we use a 3-month delay to be the base case. And we can update the model with stage-specific data once available. And we can also look into the actual data about care interruptions, but that needs to be validated, and we need actual data to do that. So that will be the next final piece of my talk today for the next 5 or 10 minutes, I guess. So how likely is the work that we do in terms of delay? So how likely can we expect a delay in Australia based on COVID restrictions? And we've done a bit of simulation to demonstrate or illustrate what the potential impact might be of a delay. So this is what we call normal queuing models. So we can develop a queuing model with estimating waiting lists based on the demand of patients. So this is the maximum capacity. This is on the left, this is a normal case with a normal capacity of 100%. So that's as the health system was pre-COVID. Whereas the green lines is the demand for care. So the referrals sent to hospital. You see there's variation. That's stochastic variation that we have to consider. But even though there's variation, we can manage pretty well with the capacity. So there's a few blue spikes here. That's referring to patients that have to wait for a day or two to get their service, So that's pretty much a normal system. There's a bit of slack in the system. We've got 100% capacity, but there's some slack here that we can manage and we can use to take care of acute care delivery. So that's the normal case. So now assume that we will have the delay. So we've got the declines in cancer incidence, which there is evidence for, and based on the information that's been flagged by Peter Mack, also about declines in referrals to Peter Mack, we can assume that's there's going to be a delay for 30% of the patients. So there's going to be less referrals to the hospital for 2 months of 30% of the patients. So this is on the right, you see this is the demand that's being reduced. And you see that if the demand is restored, if the social distancing policy are restored, we can expect an increasing demand, and we will expect a bit of a waiting list to manage those patients. But at some time, you will see, and that's the backlog of patients, you will see we can manage this. So on average, a 2 months delay, and again, this is just hypothetical data, but a 2-month delay here would take us about 2.5 months to return to normal capacity to be able to see everyone. So that's the normal case with just a assumption of a 2-month delay or a 2-month decline in referrals for about 30% of the patients. Now we're going to change the capacity a little bit. So here, in the first case, we're going to reduce the hospital capacity up to 80%. So it's going to be reduced because of social distancing and other measures. So we have a reduced capacity to 80%. So you see that, well, there's an impact, obviously, of the capacity because that goes down here, but there's just a decreased demand anyway. So there's not a big deal here. So there's a decreased demand. And if we restore our normal capacity here on the 15th of May to 100%, we're pretty much able to see those patients within a reasonable time frame. Again, we need about 2.5 months to see all those patients. So reducing capacity during the outbreak when there's less demand, that's not an issue. It's going to be much significant if we reduce the capacity even post-COVID. So here we have got, during the COVID outbreak, we've got reduced capacity. But post-COVID, we have a reduced capacity of 90% compared to normal. And in this case, we need a really long time. We probably need 4.5 to 5 months to see all those patients in a backlog because of our reduced capacity in seeing those patients. And even if we've seen all those patients, it could take 4 to 5 months to see those. But you see there's still a lot of patients on a waiting list because we have a significant reduced capacity to see all those patients. So this is just to illustrate what the impact of capacity will be. And it urges us to think about the optimal way of care delivery. So can we prioritize care delivery? And I'm assured in writing the paper that we did in the modeling, that for category 1 surgeries, there's no capacity concerns for this. If you need urgent surgery, there's not a concern at all. I'm pretty confident with that. But this is more of a systems level approach where you see, okay, if there's reduced capacity, we can have to deal with that for a long time in terms of managing those patients. So really think about prioritizing care delivery. So the other thing I'd like to talk about very briefly is what changes have we actually seen, because we want to know what's actually going on in the real world in terms of care delivery at the population level. And this is actually to credit the work of Grace Chazan. She's a medical oncologist leading the survey work, the survey that we've done. So we've submitted the survey, which was published end of April, early May in Australia through COSA and MOGA. But we also have a collaboration with ESMO, the European Society of Medical Oncology. So that's explaining why we have a significant number of respondents from international, from overseas, and about 150 respondents from Australia and New Zealand, the majority being medical oncologists. So there's a few questions. This is very preliminary, and you really have to invite Grace to talk about it in more detail when we have analyzed all the data. But if you do, we've asked a couple of quick questions about the numbers of patients that I've seen with a COVID, either infection or died from COVID. And this is not a surprise. You will see overseas, about 50% of the oncologists have actually seen patients infected with COVID, and about 20% have seen patients dying from COVID. Well, the numbers are pretty different in Australia. Up to 5% of the oncologists have actually seen patients infected with COVID. So that's pretty significant difference. But if you ask them about management, so we have asked a couple of questions about the percentage of patients, of respondents having changed their clinical management. You see even in Australia, there's a significant change in clinical management. Even though COVID outbreak is managed pretty well, we've seen a very significant change in delivery of cancer services in Australia, which is almost the same as in overseas. Up to 80 to 90% or even 100% of the oncologists actually have seen a service change. And if you ask them what has changed, well, one of the most obvious one is telehealth, broadly defined. It could be teleconsultation or just a call, where you see a significant increase, particularly in Australia. About 70% of the patients being seen by teleconsultation at the moment, which is only 50% overseas. You see a more significant increase in the number of patients being consulted through telehealth compared to overseas. And it's very interesting to have a further look into this in more detail. The survey is really promising in terms of other questions that we've asked about changes in chemotherapy prescription and reductions in treatments in the palliative care phase, for instance. So once we've got this data ready, it's definitely interesting to have a look into this in more detail. The other piece of work that we wanted to develop, and that's really early stages, is actually, can we look into the delivery at the population level? So one way to look into this is through the MBS item numbers. And at the moment, and this is very recent data, it's also last week published, where we got the March 2020 data from MBS. So this is aggregate data. We did not have any data requests, so there's no patient level MBS item numbers available yet. So we're developing a data request to get MBS and PBS item numbers to actually observe changes in treatment prescriptions in the delivery of cancer services. But this is at least gives some indication in diagnostic procedures and in the investigations for respiratory and gastroenterology and colorectal, where you see a decline in MBS item numbers being requested and reimbursed. So yeah, I mean, this is just population level data. We have to go through it in much more detail with the clinical experts to see, to give a meaning to this decline. But you can see similar trends as observed in the UK, with the declines in chemotherapy prescription and referrals have been observed in the MBS at the population level. The other interesting observation that we've found in chemotherapy administration, the use of chemotherapeutic procedures covered through the MBS. So this is not PBS item, this is really the admin procedure. You see there's a gradual trend increase to administration in the shorter episodes, less than an hour. But you see a sudden drop in the more intense 1 and 6 hour chemotherapy administration, which is well, I think it's interesting because it's not just a decline. This is a seasonal trend over Christmas that you can see here last year, 2018-19. You see the similar decline in that long administration, more than 6 hours. But that's going to be lower. So that's not explaining a trend. It seems to be somewhat an interesting observation that we've seen. But again, we have to make sure what it means in terms of clinical prescription and in terms of getting access to real patient level data. But this is confirming at least that we see similar changes in the health service delivery as have been observed in the UK. So I'd like to wrap up with a few conclusions. To summarize the talk, a simple inverse stage shift model estimates excess mortality of 19 deaths and $12 million excess healthcare costs, assuming just a 3-month delay. That's the base case that we present. We only consider the indirect effects of COVID due to care interruptions, and that's confirmed. At least the care interruptions are confirmed with the survey data that shows that more than 80% of the respondents have changed actual clinical management. And I said 70% are now using telehealth. Another interesting observation is that 57% of people are less likely to treat more intensively in the palliative care phase. That's also coming from the survey. And again, I have to talk to Grace Chazan to go through this in more detail. I've demonstrated that reduced capacity during COVID restrictions may last for several months. It could take long to restore to normal capacity. So that requires to really think about prioritizing critical care, but also abandoning low-value care. This might be less of an issue here because there's not an immediate concern in category 1 surgery, but I definitely know from Europe, there's significant discussion about low-value care, abandoning low-value care to make sure that we can prioritize patients that really are in need for urgent care. And finally, I think we urgently need to develop and maintain an infrastructure for real-time access to data. And to summarize that final slide, I mean, the data that I've presented shows that timeliness of health system performance data is critical. And all the data that I've presented coming from either the UK or the US or from the Netherlands, so excess mortality due to COVID in the UK was published on 14th April. It's only released 24th of June, the death statistics. Netherlands Cancer Institute, they flagged their concerns as early as 3rd of April, 5 weeks after the onset of COVID in the Netherlands. The UK, the Collateral damage studies, based on their large population-based level data, published on 24th of April, 10 weeks after the first COVID infection. So I think really you need real-time access to those data sources to have a meaningful model and meaningful information to actually change, to inform the government in terms of health policy. But this is not the only concern here. I mean, this is also flagged by Francisco Colombo, leading the health department in the OECD in Paris. And they say only 8 countries at the moment, which includes the UK and some European countries, have the operational readiness to generate information from EMRs to actually inform health policy in the right way. So I think it's not just here, it's everywhere, but it's critical to get this right in the next few years, particularly if more outbreaks are to be expected. And I think, and that's definitely what I'd like to contribute to in Australia, but also Victoria, we need to strengthen the data infrastructure Australia-wide. So there's a few great examples I've seen. So ePath reporting for the cancer registry would allow us to get much easier and much better and timely access to pathology data sets to inform us about cancer incidents early on, which was the source of the data that the Netherlands Cancer Registry also used. We've got the Victorian Cancer Center Data Hub that's definitely very, very instrumental to develop those linked data sets. We just launched the University of Melbourne Center for Digital Transformation and Health, but I'm particularly pleased with the Healthcare Recovery Initiative, which is a collaboration between MAC, Melbourne Academic Centre for Health, Monash Partners, and Western Alliance to talk and negotiate with the government to share the interest to get access to those data sets early on, to provide the critical information that's required to inform health policy. That's my final slide. I would like to thank you for your attention. And I just want to go back to my very first slide, acknowledging the great contributors to the work that we've done, and with including their slides. Now you can see them. Thank you very much.
Thanks, Maarten. That was a really thought-provoking and topical presentation, and raises and addresses some really important questions. And we might just get straight into some questions for you. So we have a question from the Victorian, seems to be from someone from the Victorian Cancer Registry. They're saying that the Victorian Cancer Registry currently collects data on stage for breast, prostate, and colorectal and melanoma. Can actual changes in stage be incorporated in your model when these are available?
Yeah, thank you very much for the question. Yeah, definitely. So it's pretty easy to implement stage information from the cancer registry in the model, and we've had several discussions with the cancer registry to actually work on this. So that's high on our agenda, to have that discussion with the cancer registry to update the model with more specific data for Victoria, but also look into distribution of stage information across different remoteness areas in Victoria.
Yeah, and in relation to sort of stages, you said you've done a sort of conservative model, and you've only considered shifts really from stage 1 to 2 disease. But if progressions from stage 2 to 3 or 3 to 4 were taken into account, did you look at how this would affect the estimate of the impact of delays on outcomes? I think you alluded to that, but do you sort of have an idea of how that would, what degree that would affect the estimate?
No, we've not done it in more detail, more specifically. We've had discussions within our team specific for lung cancer, whether we could use staging information at time of diagnosis in the hospital to update the model. But we are not sufficiently convinced that we have population level data on this. We can, of course, we can do some simulations. I mean, we can do everything with the model. We can simulate stage 3 to 4 distributions and see what the impact might be. But that's in publishing the work, we want to be on the safe side, rather than to be too panicking and don't want to panic too much. But it's definitely, we can do it. We can use the same population level data from the US to inform that stage progression from 3 to 4 and extrapolate whether that impacts survival, which is for sure it will impact survival, particularly for the more severe cancers, colorectal cancer and lung cancer.
Mm-hmm. And also another question, are there plans for this information to reach government and policymakers, sort of stakeholders in health management?
So I'm working at, so this, I introduced the initiative, which is led by the Cancer Council New South Wales on modeling, bringing all the modeling expertise together. I think definitely we have this discussion within our local government and within the VCCC and other organizations. But I'm keen on having that discussion going in Australia's wide spectrum. And also to make sure, I mean, we're not the only group working on this. So we want to make sure that the work that we do is aligned with the other initiatives and to be as good as possible with informing the government rather than just presenting this work as a standalone project.
All right. Okay. Well, I think we'll have to bring the questions to a close because we're running out of time here. And that brings us to the end of today's COVID-19 and Cancer in Victoria webinar. Thanks, Maarten, very much for your presentation and for the audience for tuning in. We had, I think, over 200 in the audience today, so that's great. We hope you can join the next webinar in this series. It's on July the 6th with Associate Professor Leslie Stafford. He's a clinical psychologist at the Royal Women's Hospital, and she'll be leading a panel of experts to explore the emotional needs and responses of healthcare workers during a public health crisis. So that's on July the 6th. Thanks again to Maarten and to the audience for joining us today. Thank you.